welcome to this short presentation on Maitland versus Mulligan mobilizations and how they are compared, how they're similar, and how we can take them and how they have been clinically applied in a certain study. So my name is Elena Robinson. I am a student in the Doctor of Athletic Training program at Indiana State University, and of course I will be the one presenting for you. So to begin discussing Maitland mobilizations, I'm sure you've heard of these in a general way. They follow the concave versus convex theory through applying passive accessory mobilizations or glides on joints. The main goal of these mobilizations is to treat the symptoms such as pain, stiffness or lack of range of motion, and general disability. These mobilizations use different levels of force or amplitude for different purposes, and there are 5 grades, and we'll get to that later. So looking over the theory, basically what it is saying is that if you have a convex surface of a joint, which is the surface that kind of pokes outward, if it moves on a concave surface, which is more of a C-shaped surface within the joint, the concave end is going to be stabilized, while the convex end is going to be moved in the opposite direction that the bone naturally would move. And I'll show you a picture on the next slide of what that looks like. And then second, if the concave surface is the one that naturally moves on the convex surface within the joint, the convex end is stabilized this time, while the concave end is moved in the same direction that the bone moves. And so overall, when the clinician is moving the joint, some discomfort or some minor pain may be experienced. Patient may be uncomfortable, and that is considered okay. So this is a picture of what I was talking about. On the left, you see the convex end, the circular kind of end of the bone, is the one that naturally moves on the concave end. And so the clinician would be pushing down inferiorly on the joint surface of the convex end, while the bone moves superiorly within that joint. And then as you see in the bottom left, that's the progression. The concave end does not move, it is stabilized. On the right, complete opposite. The concave end is the one that's moving, and it moves in the same direction that the bone naturally moves when the clinician is pushing or gliding that surface inferiorly. And as you can see, bottom right, convex end has not moved, concave end did. So I already mentioned that there are 5 grades. So these grades basically mean that there's a certain amount of force within each type of glide or each grade, and each type of force has a purpose. So grades 1 and 2, as you can see from the picture in the middle of the slide, they're smaller glides that do not reach the barrier of the surrounding tissue. So that basically means that they don't reach the end motion. They're just small, tiny glides, and the goal of these glides is to simply decrease pain. Grades 3 and 4, as you can see from the picture again, they are bigger, mid to full range motion glides that can reach the barrier of the surrounding tissue. So as you can imagine, since it can go that far in the glide, the goal is to increase your range of motion. This is more for like hypomobility, general stiffness, situations like that with joints. And then grade 5 isn't even on the picture because it's a little different. It's more of a manipulation. You probably hear of that more often, especially within like chiropractics. It's about incorporating a small high velocity thrust to the joint. So it goes past that end range of motion, and then a pop may be heard. It's kind of a common telltale sign that you've gotten that far. So now we're going to look at Mulligan mobilization, or often called Mulligan mobilization with movement, which basically or literally means it's the joint mobilization, but the clinician has decided to add in active movement from the patient. And so it's often called mobilization with movement, or MWM. These mobilizations are performed through typically sustained natural apophyseal glides. They are also performed in a later study I will be talking about soon through just simply natural apophyseal glides, not sustained ones. So both can be used for the Mulligan mobilizations. And then the theory focus for this type of mobilization is the positional fault theory. And this theory basically is about correcting the joint positional fault, or as you can imagine, it's positionally not correct or incongruent, and that will often present after an injury. So the goal is to correct this positional fault, and it's often corrected by the clinician finding out which type of range of motion of that area is the symptomatic range of motion, the one that produces pain, or the one that's stiff, the one that is increasing the disability of the patient, and to use force on a sustained translation or rotation of the joint area that's symptomatic. And that translation or rotation will be directed in a specific direction. And the patient would actively complete the symptomatic range of motion while the clinician is placing sustained force. So the difference between this type of mobilization and Maitland grades is that no pain should be experienced, and therefore if pain is increasing or the patient feels pain during this action, then the clinician needs to decrease their force or reposition their technique. The kind of negative thing about this is that there's no grades, and so it's just kind of the clinician has to feel around for the force that the patient is comfortable with, and may increase their force the more repetitions they perform. So the similarities of both mobilizations, very general. They both focus on targeting symptoms, pain, range of motion, general disability, and fixing those, or helping, shouldn't say fixing, but help the self-healing process. And then they both reposition joints and increase patient function in general. Both incorporate significant patient education. This is especially true for when it comes to pain. As I already mentioned, Mulligan mobilizations, there's supposed to be no pain with those. And so you would need to be telling that patient that that is what they should, be expecting. They should be expecting no pain. Versus Maitland mobilizations, some minor pain may be expected and is okay. And so definitely educating the patient on what they should be feeling and how far they can go before it's too much. A lot of feedback from the patient and the clinician going back and forth is very important for both of these mobilizations. And then lastly, both types of mobilizations, when you see studies on them, they screen their patients carefully due to the contraindications of performing these mobilizations. So now I'm going to take it back, or I guess take it forward, really, to a specific study that I found on neck pain. For me personally, I deal with neck pain. I know a lot of people that deal with neck pain. And so it's a common issue among the general population, and it doesn't really matter necessarily what kind of lifestyles, both sedentary and active lifestyles, can be affected by neck pain. It can be acute or chronic, and then it can usually be categorized within these three types of categories. So neck pain caused from spinal pathologies, from neurological issues, or it could be non-specific neck pain, which a lot of the general population has. And then often studies are done with mobilizations because general therapy has shown no improvements for general non-specific neck pain. So this is a study that I found, the comparison of Maitland and Mulligan mobilizations and improving neck pain, range of motion, and disability. The objectives of this study were to find the effectiveness of both mobilizations on increasing range of motion and decreasing pain and disability, and then as well as comparing the effectiveness of both techniques on the improvement of the outcomes I just listed. So getting right into it, the patients, there were 30 patients included within the study, ages 20 to 45. The inclusion criteria was that they needed to rate their pain greater than a 2 on the numerical pain scale. The pain and stiffness in their neck needed to have lasted longer than 2 weeks, and the pain needed to be aggravated by movement. And of course, they needed to not have anything on the contraindication list. None of that had to apply to them. So then they all completed an initial history, subjective and objective assessment, which is kind of part of the inclusion criteria to an extent. They also got goniometry measurements of their cervical range of motion in all directions. They filled out the neck disability index tool, and of course they rated their pain on the pain numerical scale. So then they were split into 3 groups, so 10 in each group. Group A was the control group. They got just conventional therapy. This basically consisted of 10 repetitions of active exercises in all motions. So study didn't necessarily say all motions, but I'm assuming that it was all cervical range of motions. And then they moved on to 5 to 10 second isometric exercises for cervical flexors, lateral flexors, extensors, and rotators. And then they all had a moist heat pack on their cervical area with their head rested on a pillow on a table for 15 minutes. So that was a conventional therapy. That was the control group. Group B, another set of 10 patients went through the same therapy, but also incorporated Maitland mobilizations. And these were consisted of grade 2 oscillations for 60 seconds. And the number of repetitions increased as the clinician felt the need for them. Specifics weren't necessarily included with that. And then the last group, Group C. So Group B was an experimental group, intervention group, as well as Group C, that had the same therapy, but also had Mulligan mobilization instead of Maitland. These mobilizations consisted of nags and snags, is like what I like to say. So like I already mentioned, snags is sustained movement, and then the nags is without sustaining the movement, or the glide, or the translation, whatever you want to say. And so the nags was less than 6 reps. The snags, just like saying that, was 3 sets of 6 reps. And then the movement, so the range of motion that was symptomatic, was reassessed after mobilizations. All these treatments were given 4 times each week, 30 days total of treatment for all groups. Pain, range of motion, disability were reassessed on the 15th and the 30th day of treatment, as well as, remember, it was all assessed before the study even began. All in all, the 3 groups showed significant improvements in range of motion, pain, and disability. Sorry, that's a typo right there. But Group C showed that Mulligan mobilizations were the most effective in improving all 3 outcomes. And so that was really cool to hear that Mulligan came out on top. I thought there was kind of a limitation to the study. There was no follow-up period mentioned. And so, after a month, basically what would it be, about a month of treatment, all the groups showed improvement, significant improvement, but there was no follow-up after those, after the treatments were complete. So that would have been nice to know. And then, I'm sorry, my reference is out of order. Clinical application. So I, from reading this study and from reading a few other studies or general information on the differences between the 2 mobilizations, Mulligan mobilization seemed to have quicker results when it comes to targeting symptoms. Within this study, The conventional therapy was also producing significant results, even though Group C had the most significant results and the biggest amount of results. So if you were to utilize Mulligan mobilizations, would be suggested from the study utilizing it with physical therapy, and it may increase your number and or timing of results. But yeah, so that explains basically the difference and how to possibly clinically apply it. And this is my reference. Thank you so much.